My name is Urta Machikena. I'm Policy Evidence Lead for Socio-Economic Inequalities and COVID-19 at the International Public Policy Observatory, which we abbreviate to IPPO. And IPPO is a project based at UCL, but hosted in partnership with institutions across the four nations, including the Wales Centre for Public Policy, Queen's University Belfast, and Glasgow University. And we work to synthesize evidence, particularly different forms of evidence, but with a focus on kind of academic evidence and research, and to bring it to the attention of policymakers in accessible formats, and facilitating exchange between policymakers, academia, and researchers of various stripes. And this event is part of our Innovations in Evidence series, which is sort of a public-facing series of events that we've organized, discussing different innovative and approaches to doing research. So we have done sessions on systems mapping, we've got one on new digital tools and rapid evidence reviews, different tools that researchers use. And recently we had another one on transferability, on understanding to different contexts. So that's the type of events that we're running as part of the series. And today the event is focused on the concept of lived experience and lived experience knowledge and research. So the idea of bringing in knowledge from people with firsthand experience of a social issue or issues into research, into analysis of how policy should be made and the best way of making policy. That's something that we hear more and more about in the policy community, the importance of the unique perspective that lived experience can provide, and the importance of lived experience to building trust between policymakers and the groups that their decisions affect. But we also know that doing lived experience research meaningfully requires a lot of thinking and resource, and has its own challenges as well. So I'm really pleased that we've got three wonderful speakers here today, panelists here today, with different, coming at lived experience from different perspectives, from academia, from the think tank research world, and from health policy, from a kind of statutory environment. And I will introduce each of them to give a short 5-minute introduction, just setting out really who they are, their work, and what they do. And then we will have a bit of a moderated panel discussion, which I will chair after that. And then we will also bring in the audience for questions and discussion. You will be able to raise your hand and speak in the discussion portion if you would like, but you are also welcome to use the chat and to leave questions in the chat as we go. And I will bring in questions from the chat as well in the question and answer section. So without further ado, I would love to introduce our first panelist. Emily Morrison is Interim Director at the Institute for Community Studies, which is a research institute hosted by the Young Foundation, whose mission is to involve communities in policymaking. And Emily is also an advisory board member for IPPO. Over to you, Emily.
Thank you so much, and hi everybody. It's great to be here today. I apologise that I look slightly bundled up. It's incredibly cold here, and I'm just keeping warm in every way I can. So I hope you'll forgive me. It's a really interesting point that I think we're at in terms of what I could call the lived experience turn in policymaking research, but also in place-based policy making and engagement. I think we've seen over the last sort of 5 years in particular an exponential increase in the appetite for peer research approaches that can gather and value lived experience. And we're at a point, I think, where it will very much depend whether that interest and acceptance scales or whether we go through another dip. Lots of people will be aware that interest in these types of evidence goes through phases, basically. And the COVID-19 pandemic, people wanting to understand particularly the complex lives of sort of people living with intersectional vulnerabilities to COVID, but also just, I think, people wanting to try to get under the skin of what had happened in the Brexit vote. A whole lot of different dynamics led to this, passionate, sort of embracing of more lived experience data. But of course, the participatory turn that preceded that, sort of really predates that by a very long way. I just wanted to talk a little bit about some research that we did just before the pandemic, actually, in 2019, where we spoke to over 35 different policymakers about why would they, what were the challenges in them accepting lived experience data? And then I'd just like to reflect a little bit more on where I think we are now in 2024. And then I'll give a couple of examples and reflections of where I think peer research works best within, the general kind of evidence space and where it doesn't. And so when we interviewed about 35 policymakers from various different parts of the devolved, power system, but also from sector, policymaking spheres and membership bodies, and we got the following kind of concerns back, and some of these won't be surprising, at all to people on this call. First, of course, about data quality, people having reservations about subjectivity, which always makes me particularly interested in the fact that, of course, we quite often as academics and researchers fail to acknowledge that all research is subjective. If you've ever read a book called We Count about the subjectivity of statistics, if you haven't read it, very much encourage you to read it. The statistical data and quant is every bit as subjective as participatory data. But that was the biggest concern faced by policymakers. And when we revisited this study this year, it remains the same. People saying you need to be honest about the limitations of the data. And, we have concerns as to, anecdotal or limited kind of representativeness in terms of, the quality of lived experience data. Credibility also, comes into a fair kind of perspective, because a lot of lived experience data is collected by peer research or by, participatory approaches. People worry about bias. They worry about whether in the effort to, promote inclusivity, we actually end up bringing bias or bringing, sort of a less objective lens into the data that's collected, basically. And it's quite difficult, quite often, to persuade policymakers or service providers who want to use peer research that a researcher who lacks formal academic training can, collect credible sources of knowledge or select credible insights. And that's a concern that resurfaced when we repeated this research exercise this year. I think there's practical things and pragmatic things, resources, collecting lived experience data. And the main reason that it is rarely done at scale, and believe me, we did it with 3,000 people in 2019, so we know what the scale and the resource needed to do that is, but it's very rarely done with, a large sample, and that's because it's very resource intensive, and it should be, because you are drawing on people's time and you need to ethically and fairly remunerate them. But particularly in the local authority environment, the service provider environment that we have now, lots of councils at risk of Section 114s, lots of budgets incredibly strapped. That is a massive prohibitor to people even embracing lived experience data at the moment, because when we quite often get requests for quotes and people will say, oh, could you possibly do some peer research for £12,000, please? And we say, no, that would be unethical and impossible and will break trust with your local communities. And when we come back with a realistic quote that involves us, we remunerate all of our community and peer research network on salary with pension contributions and proper training and accreditation, that you're looking at an investment of around £20,000 per peer researcher. That's a lot of money for a lot of clients, and they don't realise, I suppose that there's a limited understanding of how much these things ethically should and do cost. Just want to reflect on issues of power. I think this is as much something for academics and other researchers to consider, as well as policymakers, in terms of their acceptance of lived experience evidence, but also the process that you have to go through in order to gather it. Quite often we all, and I've had this so many times, from commissioners worrying about surrendering power over the topic, the research guide, the selection of questions, worrying about surrendering power over the very policy area by notion of people being more involved. And these, I suppose, inequalities, but also concerns persist, whenever we do work, particularly with private sector funders. I've had lots of experiences with housing developers and other private sector funders really concerned about that relinquishing of power. And it's a very real concern because obviously as you raise expectations through stronger and more consistent involvement, and quite often the gathering of lived experience absolutely requires that. You just can't do this properly unless you're willing to empower the people who are going to be collecting the lived experience with you. And that can be a big concern, particularly for some funders, but also for some academics and other researchers. And it's a learning curve, to genuinely share ownership over that type of work. I could go on and on. I will provide a link to that report, but just to now reflect on, I suppose, a couple of reflections on doing peer research and gathering of lived experience data. And of course, there's other mechanisms other than peer research. You've got ethnography, autoethnography, digital ethnography, long-term panels and participatory co-facilitation, so many different techniques that can gather lived experience data, many of which we use at the Institute for Community Studies and the Young Foundation, where I represent. I'd like to be a bit provocative that quite a lot of the erosion of the value of lived experience as a form of evidence has come from it, the lived experience research approaches being used on the wrong topics. These kind of lived experiences and peer research approaches is by virtue most effective when you are working with people who have a very, very in-depth knowledge of the issue that you are working to. And quite often people think it's nice to have community voice on any issue, but our experience is that community voice doesn't necessarily work on topics like future scoping exercises or net zero, for example, where people have a low socialization as a whole of the topic. They're not going to give you those sudden striking insights that take you beyond the evidence base. And that's the real value and importance of lived experience data. However, what I would like to reflect on is, from my experience, where lived experience data really sings in the evidence environment is actually, and I have to credit Sarah Chater for this because we were talking about this, only the other day. It's about lived experience data can, rather than being just something that you collect in the course of a project, it can actually skewer the policy problem in a way that the policymaker has never heard before. And I'll just end by giving one example of that. We were doing some work in a borough of London. I will anonymise it at this point, but we were doing some work in a borough of London focused on they wanted to put in new funding and structures for the development of social infrastructure and community hubs in that borough. And the funder was completely obsessed with the notion that they needed health infrastructure, more gyms, sort of more well-being programs, gyms in parks, and this, and we were being pushed quite
could I ask you to wind up in the next minute and we can come back to
I said I was just giving one example and then I'm going to cut, so don't worry. So basically the funder was completely obsessed with the notion that this infrastructure needed to be focused around health. And we were basically trying to unearth, all the way through, why would they not take a broader lens? Why was this not happening? And then when we started engaging with the community researchers as part of the project, they said very openly in a workshop with that council, everyone at the council is obsessed with the notion that everyone in this borough is fat. That's what they just said. They said they're obsessed with the fact we're all unhealthy. And suddenly the problem came into sharp recognition because, it was, why was this all being structured in that way? And the fact that the residents knew this and they could put their finger on the problem then opened, this challenge of assumptions held by the local authority that opened the window for us doing a much broader, more valuable examination and needs analysis of what was needed from the community infrastructure. So quite often, if you just flip it and think, where actually is the lived experience going to create most value? It's actually in identifying the policy problem, not necessarily just being the research that gives you a deeper understanding. But I'll stop there as I'm sure I've gone over time, and thank you very much for letting me offer some insight.
Thank you so much. We'll come back to some of those issues in the discussion as well. So I'm going to go next to Professor Debbie Foster, who is based at Cardiff University. She's co-chair of the Disability Rights Task Force in Wales, which consists of disabled people, their organisations, and Welsh Government policy leads. And Debbie was an author of the Locked Out report, which worked in a co-productive way with disabled people to reflect on experiences pandemic. Debbie, over to you.
Thank you. There's quite a lot of themes that Emily's talked about that resonate with me. Just to give you a little bit of a background, in Wales, during COVID, 68% of all deaths in Wales from COVID-19 were amongst disabled people. And that's a pretty shocking statistic. And it's one that was sobering for the Welsh Government as well, when the Office for National Statistics published that. And that mirrors a similar death rate in the UK more generally. Welsh Government decided during the pandemic to ask its Disability Equality Forum to think about commissioning a report that would be written with disabled people, but I'm an academic and they brought me into it to help them co-produce that written report, which ended up being the Locked Out report. And the Locked Out report basically detailed the lived experiences of disabled people during the pandemic and brought together other forms of evidence with the help of Welsh Government researchers. And together we wrote this report and highlighted some of the problems that disabled people were facing during the pandemic, but much wider in terms of policy. And so, you know, some of the issues that came up during the pandemic were things like disabled people couldn't socially distance. If you were visually impaired, how do you socially distance? When the government decided that priority lists would be drawn up for people to access supermarket deliveries, people with visual impairments were not put on that list, but they couldn't go to a supermarket and socially distance. I had somebody on the task force who was hearing impaired who said, how do I contact my GP? Because I go to the surgery and all that exists on the door is ring us. I can't ring a GP and have a conversation. And all these things were not catered for when we thought about the provisions that were brought in during lockdown. And these became more and more highlighted as we were discussing people's lived experiences. Now, this was quite a novel thing to have done, the Locked Out report, and when it was published by Welsh Government in 2021, they initially reacted to it, and one of the reactions that they had was that the First Minister took the recommendations in the report very seriously and said, I'm going to establish a Disability Rights Task Force, and I'm going to have two chairs. One will be the Minister for Social Justice, so there's political input into this task force, and disabled people in our forum, in Welsh Government's Disability Equality Forum, will nominate the other chair. And I was very privileged for them to come to me and nominate me. I self-identify as somebody who is disabled. I also do research in the area, and I'm an academic and publish in the area. And I've increasingly drawn on lived experience in the research and the publications that I've disseminated. And I think lived experience has problems, but it also presents us with enormous opportunities, particularly to access the realities, the real lives of people who often don't have voice in our society, who are marginalised. And they don't have voice because they're not recognised as key stakeholders, but they don't have voice also because they're often not round the table and they're not key decision makers. And I think COVID-19 in particular exposed the fact that disabled people had just been left out. And that's why the report was called Locked Out, Liberating Disabled People's Lives During and Post-COVID-19. I'll leave it there because I think you want to go into a more general discussion.
Thank you so much, Debbie. Thanks for that. Just to let everyone know, with the Q&A section on the Zoom toolbar is not enabled. So if you have questions for the panel, please just post them in the chat and I will pick them up. But you can also post other relevant links in the chat. And Emily, I think there's a question for you there from above about the research you mentioned. So I'll go next to Rebecca Curtain, who is External Affairs Manager at Healthwatch England, where I also used to work in a different life. And Healthwatch England is a statutory body whose role is to advocate for the patient voice in the health service. And health is one area where the concept of patient participation is, I would say, relatively maybe more embedded than some other policy areas, but Rebecca can comment on that.
Good afternoon, and thank you, Urta, for having me. So just a bit of background about Healthwatch. We were created just over a decade ago, as Urta said, as the statutory patient and public voice champion for people using NHS or adult social care services. And we are a network that includes both our national body, Healthwatch England, as well as 153 local Healthwatch who work in every local authority footprint in England. And we at Healthwatch England, we're funded by central government, but local Healthwatch are funded from council budgets. And speaking to Emily's point, those budgets have seen a real terms decrease over the past decade, so that can affect the ability of the network to do what they want to. But lived experience is integral to the work that we do at both a national and local level. Every day, local Healthwatch, they're not trained academics in most cases. They're just ordinary people based in their communities, maybe with charity backgrounds, who want to do good. And every day they go out and speak to people about health, well-being, their NHS or care journeys, the obstacles they face, the improvements they want to see. And so if you look up our National Reports Library, you'll see a wealth of evidence on a huge variety of topics. So for example, you know, Healthwatch Blackpool recently did a project engaging with 3,000 young people about to get their views on vaping. Healthwatch Brighton and Hove carried out in-depth interviews with new mothers about mental health during and after pregnancy. Healthwatch Hertfordshire has just recently published a collection of 20 stories shared by people with cancer. All of these engagement reports vary in size and depth, but the key thing is they're all embedded in lived experience of people. The evidence gathered by local Healthwatch is shared with the relevant NHS or social care provider, such as GPs, dentists, hospitals, or care homes. And local Healthwatch also share these findings with the responsible commissioning body, such as the NHS integrated care boards that fund local services, or local authorities who fund things like public health services, screening, that kind of thing. And they discuss what kind of improvements can be secured for people before then making findings public. And at a national level, we have a team of around 40 staff, including the policy team of which I jointly manage, who work to effect change at a national level. So our research team number crunch the data and analyse reports that are fed in from local Healthwatch databases to identify emerging nationwide problems. But importantly, we also look at issues that may be affecting smaller groups of people, but are just as important because they really hone in on health inequalities. We also carry out about 5 to 8 national research projects each year, which aim to bolster the breadth and variability of local Healthwatch research with some robust evidence that we have at a national level, both quant and qual based, which we can use as one part of our influencing toolkit with national stakeholders. So in the past month, our team has, for example, met the Special Advisor for the Health Secretary to talk about a new dental care recovery plan. We've given evidence to a parliamentary inquiry on changes to pharmacy services and met with the Cancer Screening Director in NHS England. This is just part of the bread and butter of our day-to-day work. But what's common about all these interactions is that when we're making our cases for change, we very much centre our arguments around the direct patient case studies and data on inequalities experienced by certain groups, because we very much want policymakers to imagine walking in that person's shoes. I have some specific examples about how we've translated lived experience into direct policy recommendations, but I think they'll emerge during the Q&A. So I'll hand back to Urte.
Wonderful, thank you so much. So I'm going to ask a few questions to bring out some aspects of the discussion to the panel, and then we will also bring in the audience questions. Please share your questions in the chat. I will bring them in throughout the discussion, and if you would like to also come in to speak, please raise your hand, and I will be able to unmute you and bring you in to ask your question. So one question, maybe starting with Debbie, in articles that you've written that I've read about your work and the Disability Rights Task Force, you talk a lot about how the term co-production can be understood quite differently by policy officials and disabled people's organizations. Can you say a bit more about that and the different meanings that are assigned to that concept?
Yes. The Disability Rights Task Force and the Locked Out report were produced using co-production, but we realised really when we moved away from the Locked Out report, which was predominantly co-produced just with disabled people with help from Welsh Government, that when we moved to a Disability Rights Task Force, we were actually in rooms with policymakers, lead policymakers within Welsh Government, and then there were disabled people and their organisations, representatives, and just individual disabled people there. And there was all the problems about inequalities of power. And we realised that actually people had come into the room with different concepts of what co-production was. And disabled people in particular, who've belonged to disabled people's organisations, have a historical sort of notion of what they think co-production is. And it's based very much in an academic disability studies approach of nothing about us without us. So disabled people say, you know, in the past, researchers would come along, they'd patronise us, they'd say they were experts and they knew what was good for us as disabled people and make policy. But really, you know, something called emancipatory research in disability studies said you can't make policy without co-producing it with the users of that policy and those outcomes. Sorry, I've ended up with a frog in my throat, which always happens when you least want it. So what we found was that co-production for some policy people in the room was about disabled people just coming and talking about their lived experiences and them taking that away, but we weren't quite sure what they did with it. What did they learn from it? So one of the things we decided on was that we had a series of working groups that are still ongoing. There's 8 or 9 of them in different policy areas, everything from employment to housing to transport to justice. And we decided that to even out some of the power differentials between policymakers and disabled people and their organisations, we needed a disabled person with lived experience in that particular area to be the chair of that working group and to direct what was going to go on in that working group, working with the Secretariat within Welsh Government. That even out some of the policy and the power relationships and what people thought was important. So as a conduit, disabled people could relay what they thought was important through that chair. And that meant that the policy sort of landscape was different in what you were prioritising. I'm sorry, if you want to go to someone else while I deal with my throat problem, it would be really, really useful. Thanks.
Sure, happy to, no problem.
Okay.
Maybe I'll go to to Emily next. And obviously, the pandemic's been mentioned by all the panelists as kind of a real catalyst for different, both impact on particular groups of people and also different ways of thinking about involving people. So, and I know you've done research with policymakers about their perspectives. So, do you have a thought on how policymakers' views on the concepts of lived experience have changed in recent years? And particularly since the pandemic, do we feel there's been a significant shift towards embedding these practices for future sort of crisis preparedness and big decision making, rather than just scrambling when a crisis affects different groups?
I'm going to be slightly not negative or there, but I think we got a lot better during the pandemic. To your point on preparedness and thinking about, sort of the role of both place-based communities, but also really importantly, communities with protected characteristics and intersectional vulnerabilities, which both of the other speakers can speak to much better than me. But I think, and during the pandemic, really fantastic models of ongoing relational working that gathered people's lived experience on subjects, including, the vaccine rollout and how to make that effective, which we've done a study in 2 boroughs in the UK and 2 in the US, in case anyone's interested, gathering lived experience basically about, sort of what was mediating people's hesitancy, and what was going to mediate their uptake of or compliance with COVID-19, protection measures, basically. And we also ran a series of online reflective diaries with over 500 people funded by the Wellcome Trust, looking at just in general how people's lives and then their relationship with authorities was changing as a result of COVID regulations. And that, covered trust, but it also covered literally how far they felt involved, empowered, able to influence change in their local communities. So there was really a bit of an upswing. But since then, I think, and the examples, fantastic examples by a colleague from HealthWatch, really important. There's been brilliant practice in certain sectors. So I think the integrated care system naturally is started to really try to embed community participation and the role of lived experience within, how we understand how integrated care can actually be better delivered and health equity and preventative health can be achieved. It's still in the early stages, but there's some really fantastic local interpretations of that. I think, again, led by local authorities where they have the budget, there's some really fantastic place-based involvement of lived experience. The Sheffield City Goals process, for example, is a real interesting model. We have worked on race task forces, in several areas of the country, looking at particular policy challenges people are having around racial discrimination and really listening. And people, those are long-term, very embedded working projects with, co-chairs, just as was just being said about the example of people with disabilities. But I don't think it's being mainstreamed, and where it is certainly suffering is that national government is not particularly interested. You're not seeing people trying to take this at scale. And if we speak to the What Works Centre network, or we speak to the evaluation task forces who uphold the standards of evidence in national government, and I do that a lot, you're not seeing that broader recognition of everything we learned of what lived experience can reveal during COVID. Even though, if you work out and about at local level in communities, you understand every day the value of what lived experience actually, communicates in terms of revealing hidden inequalities, revealing the hidden friction points in systems, revealing the hidden stopping gaps in terms of everything from adoption of green net zero measures through to why a particular benefit isn't benefiting as many people as it should. And we just published a report funded by the Nuffield Foundation on Tuesday, which was about looking at how the poorest were going to get to net zero. We used a lived experience approach to road test all the government's schemes that were out there, basically. And it revealed an astonishing range of factors that DESNES and DLUC and the major government departments just admittedly, when we engaged with them very proactively, said, we've never even thought of that. You know, we've been looking at income and we've been looking at housing stock, and we haven't been looking at how social relations influence decisions that people make about green choices.
I'll move on to Rebecca then, maybe to, yeah, as you mentioned, the examples of translating lived experience into policy recommendations. Can you talk a bit about that process, and how do you actually take what can often be, you know, large amounts of information about people's experiences and then translate them into recommendations, sharp recommendations that you can aim at policymakers, and any challenges and in that process and how you might address them?
Yeah, thank you, Uta. I think I might draw on some work that you might be familiar with, actually, which is looking at the use of the NHS compliance by the NHS of the Accessible Information Standard, which all providers are supposed to follow within England, to make healthcare information and communication accessible to people with learning disabilities, who have sensory issues, sight issues, or hearing issues. We used a variety of tactics to explore this issue, because we were hearing increasingly more and more people saying GP surgeries, I think, as Debbie mentioned, just aren't adopting and adjusting their systems so that people can access services in an equitable way to the rest of the general population. So what we did is we reviewed our database of local health watch stories. We had 6,200 individual stories from people across England. So we reviewed those and brought them together in themes. We did an online survey of 600 people. But I think what was more impactful is that we created video stories, we created written case studies, and we got media coverage. We used a variety of ways of presenting the information. As you know, we had data captured from survey results, we had thematic reports, we had audio and video stories, and then we had attention in the media. But what really helped is that we collaborated with all of the stakeholders in this space. So instead of having 4 different organisations each calling for slightly different things, we were able to pull together around a common goal. So instead of one deaf charity calling for all GP surgeries to make sure they have hearing loops installed, and for having sight charities calling for the specific asks for their constituency members, we were able to work together to coalesce around some themed broad recommendations that would cover all, and put them, and we also involved very early on talking to NHS England and government early on to find out the art of the possible. They were about to do a review of the standard. They were open to talking to us, and we held a working group which is still meeting today, because an updated version of the standard is just about to be published in the next few weeks, we understand, which, as far as we know, is going to meet probably about half of the recommendations that we've put forward. It's been a 2 or 3 year journey, but I think it's about working together, and just using a multitude of kind of tools in your toolkit rather than just relying on one report alone.
Great example, and yeah, piece of work that's close to my heart. I'm going to bring in some questions from the chat. I'm going to ask a couple of questions together and then bring everyone in the panel back to respond. But obviously, you may pick and choose which questions you have responses to. So there is a question from Clementine, who says, I was curious about the term lived experience and the extent to which the speakers think this is different from qualitative research. And is there particular value in using the term lived experience as different from just qualitative research? And a couple of people echoing that in the chat, saying that they've had some pushback against the term lived experience as a standalone. And so can the panel reflect on how that's received by people who aren't researchers? And then I will bring in another question. There's a question from Rihanna, particularly in relation to racism, and says, how do you promote the importance of lived experience as a form of knowledge when many people deny the existence of racism? But I think we can expand that more broadly and think about how we're trying to dismantle some of the structures which get in the way of people acknowledging the importance of lived experience, and what is the role of organizations in doing that. So I will come to Debbie perhaps first.
Yeah, in the hope that my throat is doesn't keep going. Yeah, I am a qualitative researcher, and yes, I think as a qualitative researcher, I gather data based on people's lived experiences. But in that process, I then anonymize my data and present it, and I make the decisions about what vignettes from the interviews or how I quantify certain themes within my data gets them put forward to a wider audience. I think the thing about lived experience, in terms of the research, but also the practical application of lived experience in the context of the Disability Rights Task Force that I'm involved in, is that disabled people are speaking for themselves. They are in the meeting, they're present, and they are saying what their lived experience and the variety of their lived experiences are. So I could talk about disabled people as a category in my academic work, but I cannot give the variety of different experiences that disabled people as a huge, diverse group have and convey that within my research. I think having those people around the table, but also having them around the table with other decision makers, powerful people, where they feel that it is a forum in which, and this is important, that they feel safe, that they, if they are giving their emotional labor, which really they are doing, that in some way that is protected ethically, and within an environment in which they feel able to participate openly. But we've had working groups where disabled people have come along and they've raised issues that nobody's even thought about, because perhaps we've never met somebody who's deafblind, for example, who's got two different impairments, who's saying, well, you're talking about all these things in relation to disabled people, but none of these things are relevant to me because I've got a different set of circumstances than the literature tells me that I should have, or my impairment, i.e. the fact that I'm deafblind, is giving me that experience, and I need to convey that. And we have had somebody who kept turning up to our working groups who constantly said, there's loads of literature on disability and how disabled people think and feel, but there's nothing on deafblind people. And this kept coming up at every single working group we had, that this one individual pop up and say, but this doesn't apply to me. And I think that having somebody convey their personal lived experience in a forum with people who can actually react to that, and they can make a difference in terms of policy, is really important. And in Welsh Government, I think that they use lived experience to try and understand the experience of domestic violence with policymakers. And apparently this was incredibly successful. I wasn't involved in this, but it gave huge insights into an area that people really felt it was very difficult to talk about and to gather research that could convey the experience effectively. So from that position, I think they then felt that this could be done with other groups that often don't get voice in the policy making process, don't get access to forums in the same way, that the same individuals tend to always turn up as well. Even if you're doing something on something like disability, the same groups or individuals will turn up to the meetings and give their opinions. And what we were trying to do is bring in a much broader group of participants. And we've managed to achieve that with the Disability Rights Task Force in a way that we think that hasn't been possible previously. And I do not think, as an academic, it is possible to convey simply through qualitative research.
Thank you, Debbie. I'll come to Emily next. I'll also throw in one more question from the chat for consideration. It's from Nick Targontsidis, apologies for mispronouncing that, who says, how do you differentiate between someone's individual experience and the experience faced by a whole community, and sort of mediating the expectation maybe that lived experience represents the experience of the whole community when actually the experiences are highly individual?
It's a really important question. We use typically co-analysis techniques during lived experience projects, which enables us to both faithfully represent the views of individuals with their lived experience, but also to, without us running the risk of being too over-interpretive as professional researchers, and therefore skewing, sort of perhaps where we see generalizations or common conditions or common characteristics emerging from a group of individuals. We work in co-analytical techniques with our community researchers, but also with the lived experience representatives, to make sure that those are not smoothed over. And this is particularly important in the context of people with protected characteristics. I think it's also changing how we think about presenting data, and not necessarily trying to present, a whole sample, but actually letting individual stories speak really powerfully for themselves, basically. And that isn't to say that you don't bring in wider, you can contextualize lived experience data within, wider statistical evidence. You can contextualize it within wider place-based case studies or, socio-economic and political analysis. But what you need to do is to think about maybe moving away from sort of whole samples and actually letting individual stories speak, because within every individual story of lived experience, there is, often you're looking for the experience of a barrier, or the experience of an enabler, or the experience of a discrimination, or the experience of an issue with a service design, or, with a route to engagement, just a tiny handful of examples. So we really have changed how we present data and how we present samples as well. But just on that note on lived experience, well, I would always categorize lived experience evidence as one subsect of qualitative research. It could not be more different. Qualitative research can include elite interviews with policymakers, and that is not founded on lived experience. That is founded on a professional identity, which gives them the right to speak about how they make policy, for example, or how they have seen a policy go into effect. Lived experience is very different. And one of the other interesting things is that whilst the whole value of lived experience is moving away from doing to doing with in the context of research, often people, what makes lived experience data stick out is because you're hearing from the voices of people who had no choice but to be subject to a policy or a service, or that kind of thing. So it's also very much about hearing quite often from those with marginalized or protected characteristics who are often hidden. It has very strong links to subaltern studies and to how we can really understand hidden histories, for example. Just a couple of brilliant theoretical points, essentially. So I think that would be how I would differentiate it as well. The qualitative involves selecting people to work with or to listen to in the context of research who are expert by virtue of a whole series of other things that, you know, including professional accreditation or work experience, or, you know, sort of just the power that they hold in society. And lived experience is totally different in that regard. But central to that is also, it's really important to not assume that someone holds lived experience of a topic. And you know, when we try to build samples, you know, we go out with a very open recruitment lens. You know, we don't approach people and say, oh, we're assuming you can talk to the lived experience of this. I think that's another really big misconception. And the biggest example of that is youth. You know, when you go out and people say, we want to recruit 500 youth peer researchers to talk about being a young person. And I always say, well, they might, you know, that might not be how they want to identify. That might not be the closest point of their identity. Youth is an increasingly big spectrum because of how the economic environment and our policy system confines people into, you know, marginalized youth categories, whether that's to do with safety or crime or housing or, you know, all these kind of things. So I think that's a really good example of how you have to let people self-define about whether they are the person who can give lived experience on a topic.
Thanks, Emily. I'll go to Rebecca for comments on any of the previous questions.
Yeah, I think often in this space we get hung up on labels, you know, in terms of, you know, is this person the right lived experience person we want in the room? I think again, like some of the other speakers said, it works across a spectrum. You've got, every one of us has probably been has had a health need experienced the health system. We have experience potentially of a condition, mental health needs. We may have family members we care for. We've interacted with services. We are all, carrying our own experiences. And then probably at another level, it's just that some people are better at describing that than others, or haven't been empowered to describe their own stories, or given the attention, or their stories haven't been given the value. We can move through that spectrum to have, expert patients by experience who are recruited. You look at the regulator in England, the Care Quality Commission recruits those kinds of people to assist inspectors when it goes out to services, to be kind of looking at services through a different lens. Then you've got, fully funded representative bodies and charities. But I think we just have to remember, at the end of the day, it's just about people. It's about people's experience. And also, it's a really interesting question in the chat about whether does lived experience implicitly imply marginalized groups. And it made me think about probably a big story that was in the news earlier this week about Martha's Rule being introduced. That, to me, I don't know for those of you who are not familiar, but that's one quite well-educated woman talking in a very dignified way about the death of her teenage daughter from sepsis, that was not really recognized or was ignored by clinicians. Now, because of her speaking out, without any kind of alliance to any particular patient body or organization, has managed to secure a national policy change. She wasn't marginalized in perhaps the way we might traditionally think, but she was marginalized because of the power imbalance, because within the system, she wasn't listened to. She was an educated woman, but wasn't listened to by the profession during that time. So I think we can't just say lived experience, the focus is only on certain groups. I think it depends on the issue,
All right, thanks everyone. We're running short of time as always. I'm going to bring in the panel one more time, but I won't then go back for any summing up. This will be kind of the last chance. So for the panelists, do make any final comments that you would like to make. yeah, we've only got 5 minutes, so need to keep it brief. But there's a couple of interesting points in the chat. One from Emerald about does the panel have any experience of hiring external consultants if you're only able to hire one lived experience consultant? And maybe any wider comments that the panelists would have about how, if you have limited resources, is it worth doing lived experience work at all? Is there a way to do it with limited resources that is meaningful, or is it better not to do it that way at all? And any other final comments the panel would like to make? I'll come to Emily next.
I think there's lots of different ways, and I think the other speakers have really, explained a few of them, of where, if you are on a budget, there are roles that you can empower people to take, because it really is about changing the power relationship. I think having chairs and co-chairs with lived experience for large-scale research or policy co-design processes or co-production processes can be really effective, at least because you're putting the person with lived experience in the or you're inviting them to take a role that has significant power over the process, basically. So I think that can be a more cost-effective way. Going out, necessarily to recruit a small sample and maybe not having the resources to do it ethically and well, I would always caution against in any qualitative or participatory exercise, basically. So I think it's about thinking, what's the power position that person is going to add, and then also not being afraid of having really specific studies on really specific elements. Often we think, oh, I want to do a catch-all, I want to get all of these different experiences and characteristics within a lived experience sample, and we see this all the time when people go, I want a place-based approach. I say, but there's so many communities within this place. Who do you actually want to hear from? You're going to need to do 8 studies, not 1. So those are my 2 final points, but I want to leave space for the other panelists. And thank you so much for having me today.
Lovely, thank you, Emily. I'll go to Rebecca next.
Yeah, I suppose I'd just pose one question. If you're, for example, a health commissioning body, and you're going to pay a GP locum cover to the cost of locum cover for him to leave his surgery to attend a co-production meeting on a new patient pathway, are you going to pay the same level of involvement payment to the person with lived experience who you want to attend? So we have to value people's time and input. We have to value the wisdom, the resilience they've shown in actually living with, for example, some kind of health condition or experience or trauma, as well as the practical elements of their time, having to perhaps arrange caring cover to come and attend a meeting. It's about valuing people in the room, and not just about funding bodies like Healthwatch to an adequate level, but at a very individual level, valuing people's time and experience.
Thanks, Rebecca, and over to Debbie.
I think in summary, I feel that something I'm doing in Wales is a bit different to the other 2 speakers, in that we are trying to come up with a disability rights action plan for Wales, and it will be a 10-year action plan that Welsh Government will be committed to. And so the lived experience bit is in the creation of that action plan. So disabled people's lived experiences are creating recommendations, policy recommendations, for all the different areas of the action plan in a very live way. So that sort of process of being involved in giving your lived experience will actually contribute to policy and practice and a real outcome in terms of an action plan that will then be reviewed with disabled people and Welsh Government. And this is why I think co-production is an essential part of the lived experience work that I do. And I have actually, somebody put in the chat something about, is it just underrepresented and marginalised groups that you would include people with lived experience in? And the very first project I did with lived experience was with lawyers, and they used the example of lawyers as, would you do it with lawyers? Well, I did it with lawyers, and I did it with disabled lawyers. Okay, they were marginalised within their profession, but it was really interesting working with that group because there was such an articulate group who then took the evidence the wider evidence from lived experience and went out there and tried to change their profession internally. So it was giving away the research back to the group, that the evidence that you collected, so that they could be the change makers rather than you as the academic were the change maker.
Wonderful. I think that's all the time we have, and I'm sorry to anyone whose questions we didn't get to. There will be a recording of this session available and sent out to everyone. And thank you everyone for your participation in the chat and sharing links as well. And to our wonderful panelists for your time and insights today. Really appreciate it. Please do keep in touch with IPPO, our website, email, Twitter, etc. And we'll have different events coming up in the Innovations to Evidence series over the coming months. Have a lovely afternoon.